Empower People works for disadvantaged women who are victims or potential victims of violence, including domestic violence, honor crimes, killing and trafficking or other type of slavery, and provides them shelter, proper counseling, legal support and other help required. The community work involves creating awareness and conducting livelihood programs.
Hello, we welcome you all to the third episode of Society Today. And in this Psych Talk, which is a continuation of our previous episodes that we have regarding the mental health and regarding the aspect of psychology. So today we have with us Dr. Anjana N. Ramamurthy, along with me and Shivani. So this particular episode we have kept to introduce you to the certain psychological disorders or illnesses that affect particular age groups, with reference to like three groups that we usually come across is that of childhood, then adult period, and then the old age. So yeah, that's the basic classification. So we have this session to basically introduce you a little bit about these psychological disorders. So yeah, over to Shivani, and we can begin with the general questions.
Yeah, thank you, Sumati. Since our topic is the different disorders that affect people of different age groups, since we have with us Dr. Anjana, who has immense experience, practice experience in psychiatry. So I would like to first of all ask Dr. Anjana, why is it important that we categorize individuals as these different age groups during the entire lifespan that they go through, and why is it important to understand psychological and behavioral disorders from the age point of view? Yes, Dr. Anjana, over to you.
Hi, good evening, everybody. I'm Dr. Anjana. I'm really sorry, Shivani, and I just have to leave for a second and come back because I think I'm having a technical glitch here. So just give me 2 seconds so that I can leave. All right? Am I audible?
Yes, you're audible.
Hello? So I'll just leave and come back in a second, okay?
Yeah, it's okay. Yeah. So within that period, let us introduce what Dr. Anjana specializes in. She's a consultant psychiatrist who's been working in Bangalore, and she's practicing there. She has also she also specializes in sexual dysfunctions and marital problems, and she has given counseling in that, and she has tremendous experience within the field of psychiatry as well. So that's why we arranged this session to gain the first on information from Dr. Anjana herself. So yeah, she's back with us. Shivani, can you just please
hello everybody, I'm back.
Repeat the question for ma'am if she wasn't able to hear.
Yes, sure. So the first question that we would like to address is, why is it important to understand the psychological disorders from an age point of view?
All right. We see, when we come to an Indian society, all of us have at least 2 or 3 generations in our families. And most, whether it is when you talk to the pediatric or to the adult or to the geriatric group, if you're able to identify these disorders early, if you're able to pick up those little, call it in psychiatry, it would help in the management, early detection, early management. Most of these disorders is what we suggest to all our patients. Picking up, especially if you pick up developmental delay, delay in milestones in children, there are interventions that can be done to modify this in the long run. If you can, if you can understand these warning signs when it comes to, let's say, for example, when we're looking at a child, we always inform or educate the mother to look for there's certain milestones at 3 months, at 5 months, whether it is neck control. So then what happens is if we pick up these disorders very early, we can actually provide adequate intervention to modify the course of the disorder or the disease. Most of these things, most of the spectrum disorders. So adequate intervention early in the stage can modify the course of the disorder itself. And that is why it's very important to pick these up early with an awareness of the warning signs. When it comes to, let's say, I just want to add, when it comes to adults, let's say if we're talking about mood disorders or depressive disorders, even these present with very early symptoms. Like for instance, a person who has a mood disorder will initially present with a disturbance in the pattern of sleep, in their attention and concentration. And this will help us intervene early. When it comes to geriatric, if you start noticing that they don't seem to pay attention, or they're losing their concentration, or they're losing their cognitive abilities, have difficulty identifying people, there are pharmacological interventions as well as non-pharmacological interventions, which can definitely help modify the course of whatever the diagnosis is for that particular age group. It's important to identify early. Did you get that? Does that answer your question, Shivani?
Yeah, it pretty much does.
Yes.
Yeah. So, like basically, what we can understand is that to understand disorder from this perspective helps us to intervene at an early stage and intervene so that the disorder doesn't get it worse from. So, to
Yes,
that, can you just give us an idea, like what could be the worst scenario and how we approach this situation, even if like there is a treatment for it. So, what would happen if it's not treated at an early age, and how difficult it will become to diagnose at a later stage?
Yeah. Okay. Let's say, for instance, I will go back to telling you about now under the spectrum of neurodevelopmental disorders, we have a lot of disorders like even intellectual disabilities, ADHD, autism. All these can be picked up early. Now, like about what happens if you don't intervene early. Each stage of identification of these disorders warrants a different type of intervention. Now, for instance, if you do not pick up, let's say, autism in a child, if you're not able to pick up autism in a child in the early ages, does autism persist into adulthood? Yes. And in case pick it up early and you don't intervene, that means that the child is going to have deficiencies or impairments in multiple domains. It can be social interaction, it can be functioning, it can be personal function, it can be interaction, cognitive abilities, ability to understand. There is a certain amount of reciprocative interaction that we see in children, which might not be there if this progresses. Also, apart from talking about what happens with the children themselves, it's also important to mention that as these get more severe or more serious, there's more stronger dosage of medication that might be required, that has to be given to the child later if the diagnosis is much later on. I'm not saying that these cannot be treated or intervention it cannot be done if it is identified or recognized later, but it's just that it requires a more strenuous and more stringent treatment later on than in early. When you're diagnosing or picking up any disorders early, you can make a plan and streamline And also, you can control how the progression is. We also say early diagnosis is better prognosis. Long-term outcome is better with early. Late diagnosis is not exactly bad, but compared to the early diagnosis, prognosis would be a little poor in these individuals.
Thank you so much, ma'am, for such a beautiful insight. Yeah, Shivani, you would like to add something?
Yes, yes. Thank you, Dr. Anjana. That was a great example of why early intervention is very important in such cases. And you explained autism very well. Are there other disorders that are commonly seen that you might have come across in your practice that occur during childhood?
There are a large number of, I'm going to give you a very rough idea. Intellectual disabilities, you have learning disorders, you have attention deficit hyperactivity disorders, you have autism spectrum disorders. And as you move towards mood disorders, can be picked up in childhood, can occur in childhood, but they're compared to the adult population, they're much lesser in this age group. And you could have eating disorders, you could have conduct disorders. Now, as you move, now conduct disorders are still in the younger age group, but as you move ahead towards the adolescence, then at that point of time, that 16, 17, 15 to 18 is when a personality of an individual develops. So this is the time that the individual will develop personality disorders. So they can undergo, there's this molding of a personality that happens. So individuals in this age group can develop personality disorders. Now, personality disorders are classified into three sectors. There's cluster A, cluster B, cluster C. So these are the three sectors. And these personalities that they form during this adolescent age group. Also, the eating disorders, like I'm very sure that you would have heard or seen a lot about binge eating disorders, anorexia, bulimia, all these disorders come up towards the later adolescent. Now, once they move from these are the spectrum of disorders that we commonly see between the children to the adolescents, that is in the pediatric age group. The other important thing that we have to keep in mind in the adolescent group is substance use disorders. With the changing trend, not just in India, but also internationally, globally, substance use is becoming a more frequent and common problem in these adolescent age groups. This is giving you a wide spectrum of the disorders that we would find in children and adolescents. To mention here is that also this is when I mentioned that personality is what is formed between that teenage and that adolescent group. There's also identity disorders. They are more open to talk about our sexuality or our sexual identity of late. So it is this age group that they actually begin to identify or relate to their genders. So a lot of with us being more open-minded or with people being more open to talk about these things, we see a lot of people coming forward with gender identity disorders as well, which happens in this late adolescence or early adolescent age group.
Yeah, one question that we have from the audience is like Sharon Fendis, very important question. She is asking that the mood disorder, how is it differ in when a child shows the symptoms of a mood disorder and an adult? So the question is basically, there's so much. Yeah. So
all right. So okay, I did see
the difference between and what symptoms to look out. What symptoms to look out in the early childhood?
All right. Now, when it comes to adults, it's very, I wouldn't say it's very easy, but the warning signs in adults with mood disorder are very clearly demarcated than the presentation of mood disorders in children. Like, for instance, if we were to diagnose a manic disorder or a bipolar disorder or a depressive disorder in an adult, we always tell the family to watch out for warning signs like increased activity, increased energy levels comes in manic disorders. In depressive disorders, we tell them to look for pervasive low mood, lack of interest, um, easy fatigability, all this in for 2 weeks in depressive disorders. Now, this might not be this easily demarcated in children. It can present as irritability, not wanting to talk to or interact with family members, disturbance in bowel habits, bladder habits, bedwetting. There can be appetite disturbances, not wanting to eat, food refusal, school refusal. They might, all these could be symptoms. Something as simple as plain irritability, not amenable or not being able to communicate with the child should act as a warning sign that that parents should look out for in these children. Sleep disturbances, waking up several times, wetting their beds. These can be features of mood disturbances in children as well. So this is something to watch out for. And when I say bedwetting, it is beyond the age of, we normally say they have to be dry by day by 3 and dry by night by 5. So if it extends beyond this age group, and there are other behavioral disturbances that you see during the day, these should act as warning signs in children for mood disturbances.
Right, right. That was a great answer, and also that question leads to another question that I have. So she said, Cheryl said that we find these disorders in children as well as in adults, right? And you very well explained what are the warning signs when they occur in children. Now, it is evident that some of these disorders, like mood disorders, some of the other disorders also, they get carried on when a person grows up, right? So how do they, what changes in the way that these disorders manifest themselves across the age spectrum?
Okay, so let's say that if a disorder, a lot of these disorders do get modified in their way of presentation across the spectrum of ages. So a mood disorder, like I mentioned, can be very different in its presentation in a child and can be very different in its presentation in an adult. So what happens if, for instance, we usually tell people, or if we have an adolescent who's come in with changes in personality, like excessive substance use, gang formation, stealing, robbery, we go back and look for signs of conduct, what we call conduct disorder in children. We look for fire setting, harm to animals. So what I'm trying to say is there are disorders which become a little more subtle through growth. There are disorders which will manifest in a different way. Conduct disorders in childhood later on can manifest as a personality disorder, what we call dissocial personality disorder in adulthood. Now, when it comes to mood disorders, mood dysregulation or intermittent explosive disorders, mood disorders in childhood can later on present as mood disorders in the form of manic depressive disorders. And also, apart from mood disorders, the anxiety disorders also can present in children. Like, for instance, you have tic disorders. Tic disorders are most often picked up in children, but it does not mean that they don't occur in adults. Tic disorders which are present in children, as they grow up, can become less subtle, or they can become more subtle. They're more softened in adults, and or they can undergo a change in the manifestation of the tic disorder. It can be just from a muscle twitch to later on to a shoulder jerk in adults. So these things can either worsen, be the same, or become less as they grow towards adulthood. I hope that answers your question, Shivani.
Yes, 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 it does. Thank you so much. Sumati, is there anything that you would like to add to it?
Yeah, it's just something that I have read about and crossed also my head, is that how this gender affects these disorder. In like the autism is heavily underdiagnosed, and the low spectrum of autism underdiagnosed in girls because this is how they're supposed to be, and the narcissistic personality disorder is something that is underdiagnosed in males because that is something that they are supposed to be. So yeah, so how does the gender
that is a very good question.
Affect on these disorders, or does it
Sumati, that
cross
yes.
like
Sumati, that is a very good question, and you are very right. You put it very correct. Disorders get overdiagnosed in men, and certain disorders get overdiagnosed in women. Like, for instance, when we're thinking of a cluster B personality and what we commonly call either a border emotionally unstable or histrionic personality, it definitely is overdiagnosed in women because, first of all, to be honest, they think that it is a part of the female persona or the character to function like that. And when it comes to, I could say a little bit of both. Emotionally unstable is sometimes overdiagnosed, histrionic is sometimes underdiagnosed. They think it is a part of the nature of being a woman. And it goes both ways. It can be overdiagnosed as well as underdiagnosed. And it's very important. This is where we go back and we pay a lot of attention to the diagnostic criteria that we use, whether it is a DSM classification or an ICD classification. Excessively emotional, excessively sensitive towards criticism. All these are considered feminine characteristics. So you can actually skip them if you think about how women react to certain situations. And like you said, narcissistic personality is probably underdiagnosed in men because it's considered to be okay to be bold, to be a little rough, a little ragged. But you are right, and definitely yes, gender does play a major role and does have a bearing when it comes to diagnosing these disorders in different genders. And this is not just about adults, it is also in children. If you see that even in children, when it comes to diagnosing ADHD, it's considered okay for a boy to be jumpy, running around, noisy, interruptive. The same thing is not okay in women and girls. In little girls, the overactivity, talking excessively is not considered to be okay. But in boys, it's considered to be okay. So whether there is a predilection for girls or boys having a chance to develop more of the disorder, that is definitely there. But then owing to the society, the cultural, the background that they're raised in, the diagnosis of these disorders in both the genders can be very different.
Very beautifully explained. Thank you so much for that insight. It's really helpful. So yeah, moving on, like I will hand over to Shivani if we can take this forward.
Yeah, we actually have a question.
Okay, yeah.
Yes.
Are childhood vaccines responsible for autism spectrum disorder? Oh, wow.
Okay, I'm going to go straight out and say no. There have been controversies on this topic. There have been studies which say that, there can be measles, mumps, MMR vaccinations that can lead to this, but the studies to support it are very, very few. Now, weighing whether autism, I'd like to say this, there is a definite genetic bearing. It's what we call in the medical field, what we call the nuts and two hit hypothesis. Somebody developing a disorder can have two components. It has a genetic component and it has an environmental component. Usually, when there is a genetic predilection or a predisposition to develop a particular disorder and there is an environmental insult, that is when a disorder presents itself. And this is very common. This is the same rule that applies to almost all the disorders across the board. There has to be a genetic predilection and there has to be an environmental insult. Now, to what extent are vaccines doing this? Like I said, the studies are very little, but there is a risk versus benefit ratio. So you have to understand that the benefit of giving a child a vaccine or vaccinating your child, the benefit far, far outweighs these studies or the side effects that it produces. So my answer to this would be no, but there would be people who would disagree with me.
also just to have a certain clarity, like it would be better if we would explain the like criteria for what we consider as abnormal and what can be considered as normal. So to that, like if I can add 2-3 points, is firstly that it needs to be, first of all, maladaptive. Maladaptive in the sense that it should, like, I have come across many people who just basically throw around words like OCD ho gaya and ye ho gaya. So it's not how, like, if a person is committed to arranging or organizing stuff, that is not OCD unless it's become so maladaptive in the sense that it intervenes in your normal functioning, and you have these constant anxiety to go ahead and do that, and you aren't settled without it. So the important components of considering something as abnormal, the very important criteria is of being maladaptive. Then secondly, we also consider that it poses some harm to the person around them, or himself or herself or themselves as well. So yeah, so these are some criteria. Every aspect of mental illness as well is something that is present in all of us to some extent. So the problem becomes illness when it reaches some extreme, and there are different criteria for various diseases. One is always not enough. So yeah, and I will also hand over to Anjana to give us a like better like matrix for what can be considered normal and what can be considered abnormal, because it's very important we have that sort of clarity while throwing around terms like this.
Sumati, you've said it very well when you said that yes, it has to be maladaptive. Most of like you said, that was a beautiful example that you gave. Now, what you gave is an example of OCD, and then you have something called an anancastic or an obsessive compulsive personality. Even when we talk about personalities, we don't say that we definitely, all of us have personalities in us. We're either a cluster A or a cluster B or a cluster C. So we can all be either an anxious person, we can be an obsessive person, we can be a person who is very sensitive to criticism. This can be in us, and we can still function well. Social, when it comes to functioning professionally, when it comes to functioning with your family, when it comes to maintaining sufficient interactive relationships, if all these domains with growth and development are not hindered, then it definitely need not be classified as a disorder or an illness. It comes under having, even when it comes to having certain traits, as we call it, could be having traits of that particular disorder, but need not be a disorder. It becomes a disorder when the person is unable to carry out the minimum requirement of that individual professionally, that is, at work, personally, when it comes to himself, herself, and her family members. And also, if most of the people who develop disorders are not able to carry out these functions in at least one or more of these domains, and that is when they require help. And they can identify that. Like, for instance, I can be a very happy person. I can be a very jumpy person. I can be a very energetic person. I can be a person who sleeps only 4 hours a day. If I can function with 4 hours of sleep, if I'm able to do my job with just 4 hours of sleep and being that energetic, I don't have a disorder. But at the same time, I'm energetic. I have increased rush of energy. I have too many thoughts coming into my head. I initiate an action or I initiate an activity, but I'm not able to see it to completion. I start an activity, leave it in between. I initiate any conversation and immediately switch. By the time I put into action one thought that is in my head, I immediately switch to another thing. Any work that I start is left incomplete. That is when it is called a disorder. That is when the person needs an intervention and you need help, because not only is it affecting his personal domain, it could also have an effect on his professional as well as on his family domain. So that is where the line between a disorder and normalcy comes.
Thank you so much, ma'am. Shivani, would you like to add something?
Yes, yes. Yeah, along the same lines, what Anjana explained was for adults, right? Because as adults, all of us have these domains as an important part of our lives. But when it comes to children, so children do not have these independent domains, right? So, and I've
True.
noticed that some parents are overly anxious about their kids, whereas some other parents are a little negligent, right? So where does that thin line come, and where both can be balanced, and how can parents understand that okay, something is going wrong and I need to get, I need to go consult a professional for my child.
Okay. See, the first thing that I will say is most of the time in children, especially infants, toddlers, these problems are picked up by your pediatrician. When the child is, and when usually when a child is born, the mother is given a card, a vaccination card. Along with the vaccinations, there are developmental milestones. And if you go back to your pediatrician, you will see that every time you go back for a vaccination, they're charting this thing on the developmental chart. So there is a rough, and you will see that it's not a single line that your child has to meet that single line. There is a spectrum. You have a range. There is a below range and there's an above range. And they seem to mark when did the child get head control, when did the child roll over, when did the child start walking on all fours or crawling or cooing or responding to call or waving or walking with support, walking without support. So when you go to a pediatrician, you usually know that if it doesn't fall within that range, it means that it is a warning sign that you have to pick it up. Now, this comes to the developmental milestones. When it comes to the other symptoms, maybe it is of mood symptoms, or maybe it is irritability, or it is hyperactivity. Now, when it comes to children, the best thing to do is to compare the child to other children of the same age group. Like, for instance, if I'm looking at a child who has hyperactivity, in a class, the teacher will pick up that the child tends to be more talkative, interrupts when other people are talking, is jumpy, cannot sit in the same place. So we even ask the parents this, if they have another child or if they've seen other children, when you compare your child to those children, how much difference did you see? Or if you have a younger sibling, then did your younger sibling do this at this age, or did the child's other sibling do this at this age? This is the easiest form of comparison or reference point when it comes to parents. Otherwise, I think that is about it. Most of the work is done by your pediatrician. And normally when you have these charts of milestones and you know that something is not right, other children are walking, your child is still not walking, other children are talking, your child is still not talking. If you go back to a professional, they will tell you if neck control is not
attained, I'm sorry, I think there was a break. Am I still audible?
Yes, yes, you're audible.
Yeah. If Okay, I cannot hear you all. But if there is a problem with a milestone, like neck control is not attained by 3 months, then immediately the pediatrician will tell you it's okay, give it another month, give it 2 months. Child hasn't started walking without support by 1 year, they tell you it's okay, give it another 2-3 months. So there is a range. The professionals are always there to give you that range so that you can pick up, or you'll know when intervention is required. Is that okay? Does it give you a clear idea of what I'm trying to say?
Yes, yes, that was actually a pretty good explanation, and it really even gave me a lot of information personally as well. Also, coming back to a little older kids, a little older adults, uh, do we still have Dr. Anjana, or did we lose her? Okay,
I'm sorry, you lost me for a minute there.
yeah, yeah, that's okay. So, am I audible? Yes.
Go ahead.
So, coming back to the to the older age group, as you earlier mentioned about when kids reach their adolescent phase, they start exploring their gender identities and their sexualities, right? So what can go wrong there, and what are the different sexual identity problems or sexual identity disorder that people are vulnerable to when they are going through this entire phase?
Okay. So one of the common things that we see is sexual identity disorders can present with what we normally call gender dysphoria. The individual or the child becomes uncomfortable with his or her own sex, but this is something that presents later on. What presents beforehand is that they seem to have a tendency to behave, act, dress, speak like people of the opposite gender. So, what could go wrong in these areas? Now, usually and very commonly, parents tend to get alarmed when this happens. You have to understand that gender dysphoria and gender identity problems with gender identity are no longer um, something to be alarmed about. This is not abnormal. If children tend to have an initiative, or they tend to identify with the opposite sex, then it is wrong to intervene and try to modify it. As you would see, you would also know that now the government has made it, there are legal boundaries wherein you cannot intervene and you cannot modify a person's identity, especially related to their gender. If a child is exploring, let them explore. This is what I would like to say. And this is what I tell all my patients, the children's parents. If the child is exploring, let them explore. It is very much possible that this is very transient. The exploring of the opposite gender or identifying with the opposite gender can be very transient. If somebody intervenes, if the adults intervene during these ages or these stages, it's possible that there'll be a lot of dysfunction, or like Sumati said, there'll be a lot of maladaptive functions because the children become confused. Now, apart from the child himself identifying with the opposite sex, there is another common tradition in India about dressing children in the opposite gender's clothes. This also leads to a lot of confusion in the children. By maybe around up to 2.5, 3 years, they still don't understand the gender part of it. By the time they become 5 years, they begin to understand that their body is not similar to a person of the opposite gender. Now, here is where they tend to take time to align themselves to their genders. And after 5, after 6, if you start dressing them in the opposite gender, the children become confused. I understand this happens maybe for just an occasion, but it is better to limit that. And when a person or a child starts to explore the opposite side or the opposite gender, let it happen. It is possible, it is transient. If it is not transient, then I would only say that the parent has to be supportive. It's a very common situation. It happens to a lot of people. It is because it's not something that the child does by choice. It's not my choice. It's not that today morning I woke up and I decided I don't want to be a girl anymore and I want to be a boy. You should understand that there are neurochemicals in the brain. There are hormones which are fluctuating in the individual, and this is not according to my will and wish. It is happening in my brain. My brain believes that I don't belong to this gender. I identify with the opposite gender. And I would say encourage them, let them understand, and when they need help, they will come and ask you for help. There are various platforms to help children with this. And when I say help, I don't mean to convert, but to help them identify what they're feeling, to come in terms to their emotions, to their feelings, to their identity. There are a lot of platforms which will help them in this process. Best not to intervene and try to convert or modify it according to our desires.
Yeah, this is something that we also handled in the previous one of our previous sessions as well, in which we discussed the social aspect, and how gender binary and the pressure to conform into these binaries affect the individuals who goes through this transitions, or even the psychological way of thinking, because there is nothing as specific as a category or a box of thought reserved for a male and reserved for a female. So these are only constructs that we put forward, and we assign them from the day onwards they are born. So the only thing that they are not abnormal, but they are exploring. So let them explore, be more acceptable towards the whatever choices they are making, or whatever the way of thinking, speaking, expressing themselves. Nothing is like, in when we speak in the sense of a gender, is abnormal, so to say. It's all just a construct, and it's all just a diversity.
See, what I would say is that what parents need to understand here is this entire concept of he has to be raised as a man or she has to be raised as a woman is something that we have said. But when you have that love and affection for your child, you need to understand your child does not feel comfortable being a female. Your child does not feel comfortable identifying as a male. So what you should be more concerned about is how your child feels. Your child wants to be identified as the other gender. So isn't it important? And I definitely think it is. It is important that you support them through that thought process, because if you're not there, then their first line of defense falls, their first line of support falls. And after that, it becomes all the more tedious for the child to look out and reach out and find help. So please, please be supportive. If it is transient, it will pass. If it is not, this person, this child of yours is still your child. So you have to support the child through that transition.
Thank you so much, Mr. Anjana. Yeah, moving on. Shivani, you would like to add?
Yes, that was a very good point that you mentioned about how it is the neurochemicals in the brains that they lead to all this, and it's not by people say कि this is a choice of that person, or वो जानबूझ के misbehave कर रहा है. So even a lot of parents used to say that about their kids, and especially in gender identity disorders, a lot of parents say that. So it is very important to understand and acknowledge the fact that it is not through their choice, it's just how they feel by virtue of their nature. And also because of the pressure that they go through, it is observed that there is a dual diagnosis, that they, apart from this, they also experience anxiety disorders or generalized anxiety disorder or episodes of depression. It does happen, so that there is dual diagnosis, and one thing leads to another, and it becomes really important then to sit down and sort everything out. So that was a very good and important discussion. Yes, would you like to add something, Anjana, to that?
The one thing that I'd like to say here is that if normally, why does it become a disorder? Sumati has already mentioned that it has to be maladaptive, and I did mention it has to be 3 domains. Though it's very difficult to demarcate these domains in children, you have to understand personally, professionally, and when it comes to relating to the family, there has to be dysfunction. The most common thing that we miss when it comes to children with gender identity is parents tend to bypass that personal distress. So that is where it becomes a disorder. It's not a disorder because they identify with the opposite sex. It's a disorder because they're uncomfortable with their own sex. They're not able to function in that body, in that mindset that they have. That is why it's a disorder. We don't say that the girl identifies as a boy, so it's a disorder. No, the girl is uncomfortable being a girl. She's not able to function in that body, in that mindset. That's why it's a disorder. So and this has to be persistent. It's possible, like Shivani and Sumati said, it's possible that this is transient. It can go away. If it is persistent and pervasive, and there is an external pressure to modify it, like Shivani said, there can be other problems. They can manifest as anxiety disorders, depressive disorders. I have seen a lot of children come forward with this. Adolescents who have trouble with their identity are facing a lot of repression or opposition from the society and families, and they come to us with depressive disorders and anxiety disorders, so which is adding to their burden, and I don't think that's very beneficial in the long run.
Yeah, we have a question.
Yeah.
Yes.
So Shivani, read out.
Okay. Thank you, Sumati. So we have a question by Ganesh Kumar. He's asking, how easy or difficult do you find in managing social media and mobile gaming addiction in different age groups? Also, do different international groups define these entities, or do they fall under any blanket group?
Okay, so when it came to ICD 8, 9, and 10, it was gaming addiction, even the DSM 5. When it came to gaming addiction, internet addiction, it became boundaries. Because as you know, with the changing trend and with how much we have evolved, and also thanks to the current situation, we've all become very dependent on media. We've become dependent on our gadgets to be able to function. So now, first part of it, I will tell you how difficult is it to manage when it comes to internet addiction or gaming addiction. It is very difficult because most of these disorders get identified very late. The whole early intervention part skips here. We normally have children who are using their phones to either communicate, to study, to work. But so then, if at all, if and when they're using these platforms or they're using the internet to as a part of the addiction, it gets picked up very late. So the intervention is very difficult. It is difficult to manage because there is intense pharmacotherapy here as well as intense psychotherapy. There's a lot of burden. I think both Shivani and Sumati can tell you more about the the psychosocial interventions that we have to do with internet addiction are far, far more than the other addictions, substance use. For a long time, we classified it or we used the same criteria that we used with substance addiction to internet addiction. It's only now onwards, ICD 11 onwards, that it becomes a little more clear as to where this disorder falls, what age groups, and what intervention has to be done. So, is it difficult to manage these cases? Yes. Intense psychotherapy, intense pharmacotherapy. The classification not yet defined have been classified under the addiction, have been diagnosed and treated. There are rules when it comes to identifying addiction. We talk about having withdrawal symptoms, having salience, having tolerance, being completely dependent on it. So all these criteria, if they meet, we still we've been using the same criteria that we use for substance for internet addiction. But as we go forward, yes, it forms a separate group, and they do not come under the blanket of addiction. As far as ICD-10 is concerned, yes, we don't have diagnostic criteria for internet addiction until now.
Thank you so much.
That was a great answer, and I would really agree because social media and mobile phones and technology in general has become such an integral part of our lives that um, even if personally, even if my phone goes off all of a sudden, or if I think that I've lost it, or if I can't find it, I get this, a very temporary, like 2-3 second of, anxiety that, oh my God, kidhar chala gaya. So it's it's very important to acknowledge that as well. So yes, Sumati, would you like to add anything to that?
You can continue. Yeah, you can continue. There's nothing particular. Like, yeah, it's pretty common, and I believe that the sort of dependency and the sort of like incentivization that also the social media provides, like if we see it, Anjana ma'am would be better able to tell you about this, is also that how the dopamine and also these neurochemical who like reinforce our behavior as to sense that we get so dependent on that amount of little bit amounts of dopamine or little bit amount of happiness, or one like can give you a sense of like you have one chocolate. So that's the thing with sort of, so it's very slippery slope, I guess. It's very tricky line, and it should be, it's we can't discard it, so it should be something that we walk the path with precautions and with if we are equipped enough to handle that sort of situation.
Yes.
And about
The thing is, what we normally tell when it comes to Like Sumati said, it's a slippery slope. So we have to understand where is it that you draw that line. If we have to diagnose or we have to differentiate between somebody who commonly uses an internet or somebody who is dependent or who's there's internet addiction per se, we say look for a person. There is something called craving. Craving means that the person is constantly looking for it. My phone is left somewhere. I can function. But if I'm constantly looking for my phone to use the internet or to play a particular game, that is craving. Tolerance. Today I spend 2 hours, 3 hours playing a game. Tomorrow I spend 4 hours. Then I spend 16 hours. Then I spend 24 hours. So there's that high, that dopamine rush that it gives you, and there's nothing that's enough. Then comes the withdrawal. I cannot function if I've not played 4 hours of my game. Then comes the salience. I'm ready to ignore my family. I'm ready to ignore my work. I'm ready to ignore my friends just to spend some time on the internet or play my game. And then comes this loss of control. Like I can't stop playing. Then comes this use despite harmful effects that we use in substances, wherein the person use despite harmful effects means I could lose my job because I spend so much time playing, but I don't care. I could lose my relationship. My friends don't talk to me because I'm spending so much time on the internet. I don't care. Using the internet so constantly has given me problems with my thumbs, has given me problems with my vision, has given me problems with my sleep, has given me problems with my mood. I still don't care. It has to meet all these criteria for you to say that there is a problem with the usage of internet. And usually we say 3 out of these 6 criteria, 3 out of the 6 criteria have to be met to be able to make a diagnosis like that.
That's pretty much sums up. Yeah, thank you so much. Yeah, moving on.
Yes.
Yeah, we have a question. I have heard that the symptoms of autism are exaggerated and incorrectly portrayed in the media. What are some of the common myths about autism? Yeah, so the person basically wants to know about what are the symptoms that we can identify in a person that are associated with autism, or are there any myths popular in the media?
Okay, so when you say the media representation of autism, the one thing, this is up to my knowledge, I could be wrong, but autism, people tend to confuse autism and intellectual disability, or what we commonly call mental retardation. They seem to confuse the two. So you have to understand that they're not the same. There can be delay in some milestones in autism, but it still does not mean that there is mental retardation. Cognitive, motor abilities of the child are absolutely fine. So the reciprocative, what we call eye-to-eye contact, interaction, speech, mingling with other children, all this might not be there. Children, if you have to look at things, they tend to be obsessed with a certain category of things. They're obsessed. They tend to stick to strict routines. They have a certain way of doing things. Prefer solitary play. All these are signs. So now, whether it is wrongly displayed or put out in the media, yes, there is a possibility, because then a lot of people still have difficulty delineating between mental retardation and autism. What are the common myths about autism? I would say they're socially not functioning or socially inept to do other activities. They cannot do anything as adults. They're not fit for high functioning jobs. They are incapable of forming bonds, incapable of forming relationships. No, I would say these are the myths that I have heard of. And it would be nice if you could tell us some more of the myths that you have heard about. This is what I know.
Like autism is also a spectrum, right? So there are people who lie on the lower end, and there are people who lie on the higher end. They are highly functioning autistic people. So like what I have understood is that the wavelength at which they work on is not coherent with the people around them. So they have difficulty forming relationships, but it's not that they can't have any sort of relationship. It's definitely little bit more trouble with them, but it's not in absolute term, yes or no. So yeah, that's it.
It's not that they difficulty with it, but it's wrong to say that they're not capable of forming relationships.
Yeah.
Yeah. That was a great answer. Moving on to the different disorders.
I'm sorry, I'm just going to interrupt one thing here. The other myth that, or the other misconception, or the other misidentification that they commonly have is OC or OCD and repetitive actions of autism. So it's very easily misunderstood. Repetitive compulsion can be mistaken as repetitive compulsions can be misread as autism. So what I would like to say here is that it has to be understood that autism usually presents within 5 years of age, and these repetitive movements or repetitive actions are stereotyped. They're stereotyped repetitive movements that are commonly seen, and they're characterized by impaired functioning or abnormal functioning. So it's important to delineate or differentiate between repetitive actions of OC and repetitive actions of autism. And the other important thing here, it becomes reciprocal communication.
Right. Yes. So, moving on to the different disorders, we have covered pediatrics, we've covered the adult category. Moving on to old age. So, what are the different disorders that the older people are vulnerable to? Yes, over to you, Dr. Anjana.
I think we might be having some trouble with the
Yes.
connection.
I think she's facing a network issue. That's fine.
Yeah. So yeah, basically, like we can discuss what all disorders that come under the old. Like when we talk of older person, we say that the vulnerability of having these diseases or the neurological, what we say, the functioning or the
Dysfunction.
brain has,
Yes.
yeah. So that develops and starts to deteriorate to a certain extent in the old age. Okay, yeah. So we have Mr.
Hi, I'm sorry. Again,
Yeah.
I disappeared for some time. Okay, so when it comes to old age or geriatric age group, now we have to understand that geriatric age group, we see a lot of comorbidities, as we call it. There can be a lot of medical comorbidities. There's diabetes, hypertension, and other disorders. Are anxiety and mood disorders common in geriatric age group? Yes, very common. Depressive disorders are also very common. Depressive, anxiety disorders are some of the common disorders that we see because there's a huge lifestyle change. There is a change in not just the way they function, but also how the world relates to them. So that is going to cause a lot of disturbances in the mood and anxiety in elderly age group. The other side or the other domain that I'd like to tell you about when it comes to geriatric patients is that thanks to all the comorbidities that they have, they present with something that we call organic disorders. Now, organic disorders are disorders where there is the presence of some changes in the brain owing to some medical condition that they suffer from or they struggle with that could lead to changes in their mood or personality or behavior. The other part of geriatric disorders are cognitive disorders. Now, cognitive disorders can either be in the form of dementia or in the form of delirium. Now, what is the difference? If you find, like I said, all these disorders have warning signs. So, if you find adults who have a disturbance in their sleeping patterns, in their behavior, have difficulty in identifying people, they have disturbances in their recognizing people, they have trouble identifying time or telling time of the day, they appear very confused, agitated, they seem to be reporting of hearing voices, and all this starts very acutely within a short period of time. That is when we look at something like delirium. Now, what can be the causes of delirium? Delirium can be metabolic derangements, changes in your sodium, potassium levels. It can be because of presence of diabetes, hypertension, which is uncontrolled. There can be a stroke in the brain. There can be liver functions which are abnormal. There are renal functions which are abnormal. All these conditions can produce delirium. Delirium can also be seen post-surgery, post any intervention that they've gone through. Now, coming to dementia. Now, dementia, usually we take about 6 months to diagnose, and we see impairments in multiple domains, the domains of cognition, intelligence, motor, social, personal performance. So all these areas, if there is an impairment in performance, is when we say there is people have trouble identifying. First thing is there's a sleep disturbance, identifying the time of the day, identifying people, have a tendency to forget names of people, have a tendency to not be able to recall names or relationships. So this could also be signs of dementia. The various types of dementia, what we commonly hear or what people commonly could know, commonly have heard of, can be Alzheimer's dementia, there's Parkinson's dementia, there's vascular dementia. There are multiple subdomains under vascular dementia, cortical dementia, subcortical dementia, mixed dementia. All these have multiple factors. Alzheimer's, unknown etiology. Parkinson's, we know dopamine deficiency. Then you have vascular dementia, which can be either in the form of a stroke or vascular changes in the brain, either in the cortex area, in the subcortical area. It can be a mix of all these factors that can present. Then you have the other group where you have prion diseases, Creutzfeldt-Jakob disease, all these which can produce dementia. These are the two important domains, delirium and dementia in geriatric. Also, like I mentioned, organic causes which can produce other disturbances in mood as well as personality. And depressive and anxiety disorders are also very common in elderly. Another thing that I'd like to mention here is that because of the sudden change in any, it can be retirement, it can be separation from children, which is something that we call that the emptiness syndrome. The emptiness syndrome is when a person is in their geriatric age group and their children have all grown up and they leave the house. So a house which was full, they had children all over the house, and suddenly the children are leaving home one by one and they have the sense of emptiness that fills them. It's called the empty nest syndrome, empty nest syndrome. And then there is difficulty with adjusting to retirement. They can have a lot of mood disorders associated with that change in their lifestyle or in that change in their that milestone of life. Also, apart from loss in the form of somebody leaving the house, there can be also loss in terms of losing a partner. There can be grief reactions, depressive reactions following grief reactions. So all these are also common in the geriatric age group.
Sumati, I think you're on mute.
Sorry, I'm really sorry. So yeah, thank you, Dr. Anjana, for giving us this insight. It was really helpful. Yeah. Moving on, I think we have covered all the aspects. So yeah, on the conclusion, we all get to know a little bit about the psychological disorder. And what's also important here is to understand is that how we treat normal and how we treat abnormal. We don't have a very beautiful history of treating people ethically with the characters that we find abnormal. So it's very important to understand that when we say, even the term abnormal is dropped in many textbooks and it's replaced by psychological disorder.
Yes.
Because the stigma that comes with it and the labeling as well. So all of these things also become important in the sense that what we consider normal and what we consider abnormal is not free of context. It's not
very clear.
It's not a clear boundary that this is normal and this is, and if it's even in the diagnostic criteria, they are not villains. They are not here to hurt every other person, and often in the case of disorder, they are usually on the receiving end of these kind of violence or Very rarely, and in only some disorders, we see that there are violent tendency, but it is also there. But most of the times, we see them as at the receiving end of the violence and the threat from the surrounding. So it's also
Very
important to
true.
acknowledge that, like, these things, and even the normal functioning is not out of the culture. Is like how we consider we are more functional, or it's very ableist when we say that we are productive in a particular sense. So yeah, these are the some lines that are also debate to the present now, and it's therefore becomes more important to ethically treat the people whom we diagnose with psychological disorder or illnesses.
Yes.
And these are not other people; these are the people just like us, and just very different wavelengths of their functioning, their mental processes, their history, their background, their cognitive functions. So yeah.
True. Like Sumati said, it is very true. It's for a person who is not aware, and that is something that we've been talking about so much. We're talking about mental health awareness for so long, but how much are we aware of mental health? Um, the person argues with me because there's something wrong with her is not the right stand. The person is arguing because there's not I'm arguing with you not because there's something wrong with me, because according to my perception there's something wrong there, and that is why I feel the need to argue. Isn't that how everybody functions? So does that make all of us problematic? If a person is carrying out a particular activity, it is because that person in the stand or the place that they are or the way that they're functioning, they think that is right. I am talking constantly to a voice that I hear. It is because I hear a voice. It is as real to me as it is as you are to me. As real as Shivani and Sumati are to me, so is the voice that I hear. Does it is it actually valid, or is it actually right to call me mad? Because this is my reality. Is it right to call me mad, or is it right to try and get me that help? I am acting violent, or I am acting abusive. Is it because I want to hurt you, or because I am being uncomfortable and I am expressing my discomfort in that way? We tend to shout when we're angry, but the idea is not to hurt somebody else, it's just expression of what we are feeling inside. So do you have to differentiate against these people, or do you have to lend that uh, extra effort to help them? And also does not mean that these people there are both sides of the coin. There are people who also hide behind the diagnosis, but the easier thing would be is to try and understand that, like Sumati said, all of us are on the same line. Everybody is normal. Somebody is going through something different from you, may not be by choice, maybe because of the changes in the neurochemicals in their brain, and it's as simple as that. They don't have a say in it. They don't get a say in it.
Yes, yes. Dr. Anjana, we have one last question. We'll address it quickly. The question
Mm-hmm.
is by Shreyas. He asks, does excessive manipulative disorder and negativity classify as a behavioral disorder among elders nearing 60 years of age?
Okay, so like I mentioned, we'll have to look at the contributing factors. I did mention that as a person ages, there are other contributing factors. They could be diabetes, they could be hypertension, they could be changes in the brain that could lead to these changes in behavior and personality. If this is disruptive, or if it is causing problems to that person himself, to the people around him, and there are there is maladaptivity seen in multiple domains, then yes, it's possible to classify it as a disorder. But again, it is a very individualized scenario. Requires thorough evaluation of that person to see to what extent are the multiple domains being affected. And now coming to or talking about the treatment, I have to say it's not just when it comes to this particular case scenario or this particular scenario. To every patient, though we have a protocol or a guideline that says that this is what you're supposed to do, each person's treatment is tailor made. I cannot give person A the same medication as person B for the same kind of behavior, because it might just not work. Even when we start a person on medication, we do not say, okay, take this. Today you've taken the tablet. 1 week from now, you're perfect. No. We'll ask them to come back. Come back to us after a week and tell us how you're feeling. Even when it comes to therapy, we don't say, today you did one session of psychotherapy and it's over. Everything is sorted. No, we do multiple sessions of psychotherapy. The response of each individual can vary depending on that person's surroundings, environmental factors, biological factors, psychosocial factors. So treatment varies from person to person. Diagnosis is also something that has to be done in a one-to-one discussion to check how much impairment is there in the multiple domains.
Right. That was a very good insight that you provided. So to sum up our session for today, it would be safe to say that first of all that it is very important to understand what are the kinds of disorders and understand most importantly the warning signs, because even though there is a criteria for diagnosis, these signs can vary with varying individuals due to different environmental and genetic factors that contribute to it. And also, these as a person grows older, these disorders become subtle, and therefore it becomes all the more difficult to identify it. And also, early intervention is better prognosis, right? So it is very important that we look out for these early signs, and also when we know that somebody is dealing with some issues, it is important that we don't tag them or stigmatize all this, that we have an open mind and we try to understand what they're going through and help them out in whatever way that we can. Thank you very much, Dr. Anjana, for being with us today, taking out time and providing such beautiful and detailed insight into mental health and psychology and psychological disorders. Thank you, everyone, for being with us, bearing with us, and also thank you, Empower People, for giving us this platform. And yes, we have Sumati back. So, Sumati, we were just concluding. We answered the last question that we had, and we were just concluding. So, yes, as you earlier mentioned, that it's not a choice. Nobody likes going through disorders and psychological mishaps, right? So it's all because of neurochemical activities that go on in the brain, and it's very important to understand and acknowledge this fact. So by saying that, I think we would like to conclude the session for today.
Thank you, Shivani. Thank you, Sumati. It was a wonderful session. Amazing initiative, and I'd really like to thank Empower People for this, to give us this platform to discuss something that is so important in today's time, to talk about mental health. Thank you very much, and thank you very much, Shivani and Sumati.
Thank you. Yeah.
Almost all of us want to do something for the larger society and try to give back to our people. But we all have limitations. We see and feel for people in difficult circumstances, and we also know that the lives of people living in extreme poverty and in difficult conditions are inevitably bound with our own lives and identities. Let's come together, speak your mind, share your ideas, and together we can work to improve the lives of people in need. Join us for online meetings. Let's discuss and plan the way forward. As shall you use your expertise, so shall others, and together we can truly make a difference. Our target is to rescue women in slavery, women who are bought and sold like products in the market for the purpose of marriage, women who are then mistreated and abandoned to their own devices due to lack of support from the family, the community, and society at large. They constitute a new generation of the oppressed. A denial of their basic human rights is the biggest threat to our development and sustainability as a species. As a first step, simply come and register at our website www.empowerpeople.in. our team will get in touch with you. We look forward to seeing you join hands, hearts and minds with us. Add in your bid to keep the flame of compassion, service and humanity alive.